Please welcome Assistant Vice President for External Affairs at NCQA, Andy Reynolds.
Good morning, and welcome to day 2 of the Health Innovation Summit. Our conference got off to a strong start yesterday, and this morning we're kicking off what promises to be a full and stimulating Tuesday. I have some news that grabbed the attention of many of us this morning, and that is the number of attendees at the conference doubled overnight. And that's because today, another 1,500 quality advocates are watching select sessions from this room live online. We understand that many people were unable to join us here in Orlando, so we offer the live stream as a way for friends of quality to stay connected to the conversation and to help them learn from the same experts you're hearing from today. So, to our online audience, thank you for joining us. We're glad that you're here. In this morning's live-streamed session, NCQA founder and president Peggy O'Kane will be joined in conversation by Dr. Jon Blum. Dr. Blum is Principal Deputy Administrator and the Chief Operating Officer at CMS. He was also the Deputy Administrator and Director of CMS in another presidential administration from 2009 to 2014. He's worked extensively with health plans and altogether has had more than 25 years of experience, private sector and public sector, in healthcare policy and administration. For this discussion of what the CMS strategic framework means for quality and value, please welcome Peggy O'Kane and Jon Blum.
Good morning, everybody. Thanks for being here. So we're thrilled to have Jon Blum here today. He's the deputy, as you heard, deputy administrator of CMS. And over my long career, I've watched CMS play a more and more pivotal role in advancing quality. And I feel like for the first time, we feel very much aligned with CMS around much of the quality agenda. And I'm probably going to ask him some awkward questions today, because having that kind of impact comes with, kind of political realities and kind of people who don't understand those or who do all too well and so forth. So I just want to say how much I respect you and the work that you do. So I wanted to ask you, last night I saw you and you said that you'd been traveling the country and talking to different kinds of healthcare organizations. So I'd just like you to talk about what you saw that excited you and what you saw that concerned you.
Sure, thank you, and thank you for the chance to be here today. The CMS team that's here today is so excited, but also so humbled that so many folks traveled here to help CMS programs work better. And just to respond to your question, I've been really trying to get the agency to get out of DC, and so I think for too long that CMS really has been a very DC-focused organization. And so part of our strategic goals is to really make sure that CMS policy is much more responsive to what's happening throughout the healthcare systems. And so our teams have gone out into the field. I've personally now been to all CMS 10 regions throughout the country. That includes large urban areas, suburban areas, rural areas, frontier areas. And I think the thing that we've been struck with is how fragile the healthcare system is. And I think there has been an assumption that if you just work to expand coverage, and today CMS is covering more than ever people through our programs, but that's no longer sufficient to ensure access to care. And so we've seen tremendous strain throughout the healthcare system. Kind of a few things stand out to me. Our team has tried hard not just to see the best in healthcare, but see those who are struggling. And so we've toured 2-star facilities, 2-star nursing homes, to see what it's like to find staff and to really struggle with providing good patient care. We've seen folks who are trying to build back value-based systems. We've seen in parts of the country, Puerto Rico, for example, that's having huge population changes and can't find enough physicians who are all leaving the island to come to the mainland, and just seeing what it's like the healthcare workforce changes rapidly. So our team is struck with how fragile the healthcare system is. In the last couple of months, we've certainly heard more optimism. We've seen the healthcare system really begin to come back since the past 3.5 years. But we have a lot of work to do together to ensure that we can ensure access. And it's no longer sufficient just to cover more people. We have to build back the healthcare systems.
That's so encouraging to hear. And, you know, you're referencing access to care, and we were at a small group last night, and John asked how many people have tried to make a primary care appointment, you know, recently. And we had a lot of people put their hands up. One person couldn't get one at all. I had one come up in 6 months. You know, just crazy. And, you know, we all know that many primary care physicians have retired. We know that many have been acquired by somebody. There's all kinds of market changes going on. And here, this pivotal role in you know, integrated care management is the most depleted. And of course, we all know that's part of the payment model. And, you know, I know that CMS, and John even said it last night, is looking at how they establish payment. And I think part of it is in a kind of a redefinition of the role of primary care, and also of what the construct is. You know, Marcus Welby still lives in the minds of many people, but we, you know, with digital technology and with you know, really functional team-based care, which is not easy to achieve, we think that the capacity of the primary care physicians can be stretched. Part of what we see, though, is there are a lot of little business models out there that are not going to serve our interests well. So fragmentation is the big risk, I think, of what's going on. So we have a new virtual primary care program that we're launching, and we're doing a pilot, but I don't want to talk about us. So I just wanted to say that I think we need to kind of figure out how to align our efforts to get to the right place. And I want to ask you about another thing. And, you know, we're all about digital. We started out talking about digital measurement, which we thought, okay, that's the transformation. That is only the beginning of the transformation, you know. So we have a vision of data that comes out of the process of care and that flows effortlessly, and that the practitioner doesn't have to kind of drive, right? The process of care feeds the data for quality. That's the goal, which will be a great step forward. I don't have to tell you all. But there are things in the way of the future that we want to see. And I was just talking to Pat Wong out in the hall, and we were talking about information blocking. So we have all this diabetes. We have a lot of diabetes sessions here that are fantastic, and Helmsley is funding them. But we were shocked to discover that the data isn't available to practices unless they make some special deal with the manufacturers. So we think this is a common agenda for us. I wonder what you think about that. Sorry to talk so much. It's really about you.
We agree. Yesterday we were talking to 4 ACO organizations here here in the area, and just asking the question, how's it working? What's working well? What's not working well? And what was really exciting to hear was just the commitment towards value-based care, and the commitment towards serving CMS populations better. What was disappointing to hear was that the systems weren't talking to each other. And so what all 4 ACOs said is that when a patient gets discharged from the hospital back to the primary care organization, the ACO, that conversation doesn't happen between the handoffs. And so back in 2010 or 11, when CMS wrote the ACO regulations, the premise was this warm handoff. This premise was there was going to be this team that would surround the patient when he or she was having a significant healthcare event. That is a real opportunity for savings. And yet we're 10, 12 years later, and we still haven't figured out ways for us to really coordinate the warm handoffs. And the things that should be easy, simple, are very complicated to do. My wife takes 4 chronic care medications. And each time she has to have those medications refilled, she has to see her primary care physician for drugs she's been on for 10, 15 years. That shouldn't be the case. And her primary care physician just left the practice, so she's stuck trying to figure out what to do. So I think we have certainly made the programs better. We have certainly built better infrastructure, and we really commend the NCQA for helping us do it. But we still have not yet solved some of these foundational challenges for how the healthcare system can talk to each other better, for how we can think about the warm handoffs, how can we think about the transitions of care. But if technology can help us do it, we're all for it. But I think one of the other barriers is that the business models have taken over sort of the purpose for care transitions. And in the spirit of trying to solve the business case for value-based care, there's more fragmentations, more pieces in the process without sort of the kind of basic premise. How can we transition the patient safely home? How can we make sure he or she has a care team that surrounds him or her during a new diagnosis? That's what we need to solve going forward.
I just had the opportunity to visit a hospital at home situation, and it was so incredibly impressive. And they had also a very low rate of discharge to nursing home, of course. And of course, it's not everybody that is that they're treating in this way. But you could see, a sniff at home model kind of embedded there somehow, and you could even see proactive monitoring of the patient before the admission. But if you're a health system and you're going to forego the cost of the admission and the money that comes with it, you have no motivation to do that. So, I mean, I don't have to tell you, CMS has been loudly proclaiming its commitment to value-based care, but what about the kind of reluctance of, let's say, hospitals to give up their traditional business model?
I think during the COVID pandemic, we were talking about this too yesterday, that the COVID pandemic gave us the opportunity to really challenge some core assumptions. It challenged what it means to go to a hospital. It challenged what it means to get face-to-face care. It challenged what it means for physician supervision rules. All 3 of those elements got blown up during the past 3.5 years, and CMS had more tools in order for us to give more flexibilities due to the public health crisis. So that's now over. So now we have to think, what is the future state going forward? It is clear that CMS needs to take those 3 elements, more of them, of what it means to think about site of care, what it means to think about virtual versus face-to-face, what it means for giving more permission for clinicians to top at the full practice to their license. The hospital home program, it really is a good example. Despite, I think, what folks had feared about lack of oversight or control, the program works well today. We kept very few cases that would cause us concern. Congress will have to give us more authorities going forward for how we think about these programs permanently, but what CMS is fully committed to doing is to be transparent, to say which waivers work, which waivers didn't, what's the data showing us. The CMS team put out some data recently just to say, here is the experience, the raw numbers, the raw case counts for the hospital. at-home program, which really are encouraging. So I think the COVID pandemic gave us a 3.5-year natural experiment for us to test some foundational elements that have been one of the silver linings to the past 3.5 years.
I agree with you, and it's music to my ears that you're thinking that way. So I'd be wrong if I didn't ask you about the relationship between health plans and CMS. And, you know, we've heard a lot lately about MA plans and coding, and, you know, you changed the formula for the STARS program. So I wonder if you could just talk about that a little bit.
I think one of the surprises for me coming back to CMS the second time is how much our programs have shifted towards managed care delivery. And so that means several things that CMS has to do differently going forward. So last year or 2 years ago, we crossed a line where Medicare beneficiaries, more than half now, are receiving their benefits through a third-party managed care organization. And some of those beneficiaries made a full rational choice, and some of those beneficiaries were compelled by their state, their employer, to shift coverage. For the Medicaid program, that is now the largest CMS program, most beneficiaries receive their care through third-party managed care organizations. And those who are in private coverage, by definition, get their coverage through a private health plan. So we have to think differently going forward for how we achieve the same goals towards value-based care delivery in an environment where most CMS beneficiaries, most CMS covered lives are getting their coverage not through CMS directly, but through a private managed care plan. So if we want to think about care transitions, we want to think about care value, we want to think about value-based care, we have to use CMS levers to really push health plans harder to ensure that they are also putting in place the same goals that we have. Some things that we see in the marketplace are quite concerning. You see code growth, risk adjustment codes continue to grow rapidly, and I think part of that is due just to the business models that are out there and to try to improve coding. We see marketing. I was watching television last night, and the ads that are run, seem to not necessarily share CMS values. So that has gotten better, but it hasn't gotten to a place where it needs to be. We saw in Puerto Rico, for example, 4 or 5 health plans that compete vigorously for just about 95% of the covered lives. They offer every supplemental benefit you can think of beyond what you could even describe to be healthcare related, but they're not building the network. There were patients who were trying to get hospital care that couldn't get hospital care because the health plan with the physician organization were in a huge fight and didn't have a contract. So CMS needs to be a partner, needs to ensure that we're being transparent, that we're providing support for how we want to push health plans harder to put in place the programs that we all value, but we also need to be tougher regulators and to make sure that those who are signing up for health plan coverage, they understand the benefits they're signing up for, that if you want to offer supplemental benefits like food supports and transportation and housing services, that's a good thing, so long as you fulfill the basic requirements of your network, your benefits that are covered by Part A, Part B, and Part D, and CMS will get tougher there. We also don't have very good line of sight to how Medicaid managed care organizations participate. And so we have data that shows that some plans put in place a lot of friction. So CMS wants to get smarter, wants to get better to really define standards for how we think about Medicaid managed care going forward.
So NCQA, in our strategic plan, one of the things that we hope to do a lot better about is substance abuse and mental health. And I feel like, there's a CCBHC program, which I think is great for, it's very important, very needed, will hit a lot of the people with serious mental illness and so forth. But in general, this problem of access to behavioral health is such a conundrum I think it's for you, it's for us, it's for plans. You know, I was talking to a friend who's here, who's a behavioral health practitioner, and she was describing what it was like. She was still seeing one patient and all the hassle that she had to go through. So I don't know. I mean, how are we going to approach this? How are we going to align ourselves? I mean, I think it may be more of a problem with the younger population, and especially adolescents and so forth, but it's clearly a huge problem. What do you think?
I totally agree. I think one of the challenges that we see is that the traditional insurance model doesn't necessarily serve patients that need behavioral health care services. And I saw this during my time working for Care First, that most clinicians, behavioral health specialists, choose not to take insurance. And so you can elevate the payment rate. And during my time at Care First, we were paying far more than Medicare just to build a network, yet it was still very challenging for us to build a network. And so I do think there needs to be, that will hopefully come with time, a much stronger trust built with payers to behavioral health specialists to ensure they work with on healthcare coverage. There needs to be much more commitment towards reimbursement, and CMS is doing everything we can in our authorities to ensure that we pay fairly. But I think what's exciting, and I think what's positive that's now happening within the healthcare delivery system, is a much stronger recognition that we need to embed behavioral health specialists, be it for addiction or social support services, for example, to the primary care practice. And that is exciting. And so I think that CMS needs to do more to embrace that. And so we have new payment codes running through our fee-for-service Medicare system that will really embrace that team-based care. But that, I think, will be our future, is just more trust, more infrastructure, but the demand for services will not change anytime soon.
Yeah, that's very interesting. So I just want to pivot and talk about your strategic plan for quality. And for the audience's sake, the priorities are advance equity, expand access, engage partners, drive innovation, protect programs, and foster excellence. So my question to you is, like, where is this going really well, and what keeps you up at night?
I think what's going really well right now is we are building a foundation for CMS that we recognize that most people during their lifetimes will be covered by CMS programs, not once, but several times during their life. Be it due to having a brand new baby, due to disability, due to a change in job, due to retirement, turning age 65, what have you. And so where we are building the foundation for CMS is to work less in our silos, Medicare, Medicaid, Marketplace, and more as a more unified experience. So the quality agenda, for example, that our team is putting in place really recognizes that we can no longer afford to have 3 separate quality programs for Medicare beneficiaries, Medicaid beneficiaries, Marketplace consumers, but a much more common experience. And so I think a vision that our team has is that no matter the insurance coverage, that a physician working with a patient will have a much more common experience. That it shouldn't matter if the patient's covered by Medicare, Medicaid, or name your insurance plan, the patient just gets good care. The incentives really are pointing to the same direction. And so we do this work for several reasons. One, just recognizing that the population in our country has a very transient nature to their health insurance coverage. Physicians, clinicians, due to the fragility of the healthcare system today, cannot afford to be managing multiple programs and trying to understand what Medicare, Medicaid, Marketplace, private insurance really is trying to accomplish. But we see our mission as taking waste out, as really making sure that our programs work more as an integrated force, and that is going well right now. What is worrisome, again, it goes back to the first question of this fragility of the healthcare system. And so if CMS wants to accomplish our goals to cover more lives, to reduce costs, to improve health, CMS doesn't own those tools. CMS pays providers, regulates providers to accomplish these goals. And so we need to be able to make sure that we're doing everything we can to support a care system that is still rebuilding since the past 3.5 years.
Thank you very much. We're very excited about the Universal Foundation.
Good.
And, you know, you didn't mention burden. You talked about it from a different angle, but I think it's been understood by Mary Green and others at CMS that this was part of the problem, that we were all measuring the same thing differently, and yet it's hitting the practitioner as like, which one do you want me to pick? What do you want me to succeed at? Yeah. So if people have questions, can you go to the mic? I have another question or another topic I wanted to bring up. But if I can't see very well, so somebody's going to have to like speak up or something after Jon, after we talk about the next topic, which is health equity. And I don't know if you know, Jon, but 20% of our sessions at this summit are on health equity, and we've got a fantastic group of speakers, and it's just fantastic to see the excitement around this. And we're also thrilled, and you heard it from me yesterday if you were here, that we just won an award of a contract from the Office of Minority Health at CMS to do 5 years of work on, and it's taking quality to a more specific level, so particular conditions, and you probably know if you're from a health plan, that we're stratifying HEDIS, and so we're going to make it possible to actually see what's going on, which of course is necessary before you even do anything, right? So anyway, I wonder if you have any comments about that.
And that, for CMS, what's been gratifying and exciting is that all of our different policy teams, but also the operational teams, has really made healthcare equity a foundation to their work. And during our first couple of years in 2021-22, we spent a lot of time just trying to define what we mean by healthcare equity, to ensure we have a good, solid definition. We are now pivoting towards building more plans to operationalize those goals. So, for example, we are putting in place much more clinical programs throughout CMS that are really trying to address core care gaps that we see. For example, diabetes care, for example, care for cancer patients. So we are at CMS just on the cusp of really building the operational foundations for how we begin to change CMS programs so they are more responsive. But for us, this is not a single office that thinks about this topic. This is a foundational cultural change running through the agency that we think really is a model for all healthcare organizations.
We agree, and same way with us. So I see 3 people at mics, and we have 4 minutes, so we'll have to like not make it too long. And I think you were first, and if you could introduce yourself and say where you are, and I'm going to go to you next on my left, and then to you. So thank you.
Thank you. Good morning, and thank you for your comments this morning. Several things resonated for me. My name is Makai Crowley. I'm an internist, board certified in internal medicine and hospice and palliative medicine.
Thank you for your work. And
COVID destroyed my practice. I was a small independent physician that could not survive the out of office component of that. Additionally, so then I went to work in the hospital during the pandemic and worked in industry. And I saw sacks of cash in the MA and ACO world being delivered outside of hospital doors and health system doors and insurance company doors. You talk about the fragility of our healthcare system, and the reality of it is, how long does it take to make a primary care visit? And it takes a long time anymore. I see my colleagues who have retired. We're aging 10,000 Americans a day into the Medicare system, and there's nobody to practice. Hospitals, I've seen how the sausage is made. Hospitals, ACOs, health systems are figuring out ways for any risk-adjusted bonus to go back not to the physicians and the nurse practitioners and the PAs who are doing the frontline patient care work, but, and really we're destroying independent practices that are the safety net for many of our rural areas. I grew up in rural Maine, and we don't have the benefit in many of those areas of having large health systems have a presence, because it's not sexy, it's not beautiful, and it has to be done in a very cost-efficient way. So I was wondering if you could speak a little bit more toward how are you going to support those private physicians who are out in rural America trying to do their thing in a way that is not supported by health systems or ACOs?
Yeah, thank you for your... Thank you for your comments, thank you for your work, and I'm sorry to hear about your experiences, but it's not surprised, and it's very similar to what we hear throughout the country. I think we payers, and CMS is in this, this bucket, have made a huge strategic error in defining value-based care as the evolution of more delegated risk. And that means that then the physician experience is not what value-based care really is trying to accomplish: more time, better care, more team-based care for that patient. But instead, what we hear from physicians is that their lives are spent coding, charting, and they are much more on the fee-for-service churn than ever before. So this rush to risk, this rush to delegated risk, that people can claim now checks a box for more value-based care, I think has created the dynamic that you're describing, are part of that dynamic. So we have to change that. We all have to change that definition and come back to a more patient-centered definition for what is accountable care. Chances are that it's better produced, that individual physician setting. We have to be more demanding that hospitals will think about that warm handoff back to the primary care physician when a patient leaves the hospital. So we have a lot more work to do, and part of that work is to change the definition for what it means to have more value-based care in our healthcare system. It is not delegated risk. It might be one element for certain models, but if that's our end goal, then I think we're going to see a lot more of the experience that you're describing happen throughout the country.
Thank you.
Thank you for your question.
All right, we have 0 time left, but if you have a real quick question, maybe John will have a quick answer. And I thank you for sitting down over there. We only have time for this. Oh, all right, you don't want to ask your question? You can go ahead quickly.
It was next, you had mentioned.
Okay.
It's a question, but also a comment. So I'm from Missouri, and I've worked with both FQHCs and rural health clinics, and I'm spending a lot of time out in the rural areas, and what I'm seeing is we're losing a lot of critical access hospitals because they just can't financially make it, and the rural health clinics are struggling. And it's in the disparities of payment reimbursement for rural health clinics. Has CMS thought about providing any adjustment, especially for payments for rural health clinics, to keep them out in the rural health areas?
The short answer is that we are eager for suggestions or thoughts or ideas for how we can shore up the rural healthcare system. It turns out that we have to operate this is an area that's hard for us to kind of more harmonize, but we have to operate separate payment systems in Medicare and Medicaid, and that's a challenge for us. But there is an open call to anybody in this room that if you can help us figure out ways for us to better pay for services within rural healthcare settings, we're all ears. That could mean an all-payer model that a state wants to help support. That could mean us really challenging the overall payment structures, but there is an open call here and throughout the country to help us figure out ways for us to pay for rural healthcare services. The current models do not work and need to be thought differently to pay for services that you're not performing.
That's very exciting to hear. I think there's so many possibilities. Please join me in thanking Jon for his incredibly thoughtful answers.